So we will go right from basics. I think the important thing to understand is if your sample is collected wrong, you will get a wrong report. And a wrong report means wrong diagnosis, wrong treatment. So we'll spend some time in telling you about things which you normally are not taught. Where to collect the blood from is not the femoral artery. It is always the radial artery. If you can do the radial, go for dorsalis pedis, I don't mind, but never a femoral artery. Because it's too big, and I've seen at least 2 cases in the last 30 years where there was gangrene following spasm of the femoral artery. How much heparin should be used is again very important. Heparin is extremely acidic, and therefore you will have a very high pH. It's a very low pH if you use too much heparin. The amount of heparin you should take is just a few drops in the syringe, roll it around and push out all the heparin that is possible, so that it only fills the inside of the needle and a little bit of the spaces, but not like one sample I got, the nurse had put 1 cc of heparin with 1 cc of blood. That's too much, just a few drops. Preventing air contact is very, very important. Okay. Transporting it, how to transport it, and clinical information that the FiO2 you should write. Now, people believe that to prevent air contact, I can either cap the needle with this which you get. It is useless because there is still air in contact with the blood. Or they say we can bend the needle and think that it is over. But if you see, there is a small capillary which is still patent, and you will have contact with air. What happens when you have contact with air? This is a hypothetical scenario. Suppose the patient, this is just a duplicate, it has a very bad lung. PO2 is 30, PCO2 is 80, very bad. But it comes in contact with air. Air has a PO2 which is very good and no PCO2. So obviously this PO2 will go inside and this CO2 will diffuse outside. So that after some time, you will get a PO2 of 90 and a PCO2 of 42, and you will get a report showing this. Reality is this: PO2 30 but you said 90, PCO2 is 80 but you get 42, and you say everything was alright, suddenly patient died. Actually it's not suddenly, it's the simple thing like contact with air which gave you an erroneous report. And the only way to make it airtight is remove blood, at least 1 drop should come out so there is no air inside, and then put a rubber cork. And if you don't have a cork, then CBC bulb, you have that rubber on top, use that and block the needle. And very important to rub, to roll it. People feel it's below dignity, they just want to do echoes and hi-fi things. These fundamental things lead to wrong reports. Roll it and then send it. And don't have to put it in ice unless it's going to be more than 4 hours for you to transport that blood to a laboratory. Today, blood gas analyzers available in the hospital or nearby. 2 hours, no big difference. Alright, you can just send it without and not waste time putting it into ice. And certainly, you need to cover it on all sides with ice and not just this. That having said, let's go into how you approach an ABG. You have, the art of ABG reading is to go step by step. Just like when you start a car, you start in first gear, then second gear, then third gear, then fourth gear. You don't do third gear, then first gear, then fourth gear, then second gear. You don't do that. Same way you must go systematically. And the first thing is check reliability of the report. You don't have to do this unless it's not matching with the clinical picture. You check it. Then don't look at the report. The biggest mistake in reading a blood gas is you just look at that paper and start diagnosing. Don't look at the paper. Before you look at the report, look at the patient. What has he got? Because you may find a pH of 7.4, which is normal, PCO2 is 40, which is normal, PO2 is normal, bicarb is 24, and you say everything is alright. But the patient is vomiting. Now, if the patient is vomiting, he should have metabolic alkalosis. Why is he not having metabolic alkalosis? If I look at it and say I am not finding metabolic alkalosis, I will now suspect a metabolic acidosis which is balancing the metabolic alkalosis. Have you understood how this is so? Okay. Now, so always look at the patient first, suspect what you will get, and if you find it, well and good. If you don't find it, something else is going wrong. And then look at the report. And when you look at the report, always answer 3 questions. What is the oxygen status? What is the ventilatory status? And what is the acid-base status? You are the doctor on duty. A 54-year-old non-diabetic comes to you on irregular treatment. He is on 2 liters of oxygen, blood gas shows you a PO2 of 108, PCO2 of 30, PA 7.2, bicarbonate of 15. What is going wrong? Anyone? Any postgraduates here? No postgraduates in the audience? Yeah. So why don't you answer? What do you think is going wrong here? You're a clinician, patient comes to you. What is going wrong? In the interest of time, majority of you would say you've got diabetic ketoacidosis and probably sugars are very high and you need to treat it. There are 2 golden rules in critical care. 2 sacrosanct rules which you must never forget. Anyone knows the 2 golden rules of critical care? Assume nothing, trust no one. Only 2 golden rules in critical care. Assume nothing. You should never assume that this patient is diabetic ketoacidosis. Machines can go wrong, and the next step you must do is check whether it's reliable. Electrodes which analyze it tend to drift with time because protein gets deposited on the membrane, and if you don't periodically maintain them, then you can get this error. And the way to do it is H into HCO upon PCO2 is 24. Normal person, you don't have H values in the blood gas report, you have PCO2 and bicarb. Those are here. Normal bicarb is 24, normal PCO2 is 40. How do you get H? Very simple. You take the pH, first 2 digits after the decimal point and subtract from 80. So 80 minus 20 is 60. H becomes 60. At pH of 7.3, 80 minus 30, 50. That way you can get the H value. Normal pH is 7.4. So 80 minus 40 is 40, and this you get this. In this patient, what was happening? pH was 7.2. So 80 minus 20 is 60. Bicarb is 15, PCO2 is 30. And here you get an answer which is not 24. So this report is wrong. Have you understood? Though if the report is wrong, then you cannot go on further treating this patient. Second, look at the patient. Would you mind if I sit down? Okay. Because I'm just recovering from a bad flu. Okay. Now, so when you look at the patient, you as clinicians know that if you have diabetes or diabetic ketoacidosis, you're suspecting metabolic acidosis. If he has got convulsions, hypotension, you suspect lactic acidosis. If he's taken alcohol, you suspect acidosis. So you know from history what disorder to think about. When do you suspect metabolic alkalosis? When they're vomiting, they're hypovolemic, they're hypokalemic. Okay, you suspect metabolic alkalosis. When do you suspect respiratory acidosis? COPD, inadequate reversal of anesthesia, muscle paralysis, GB syndrome, myasthenia. Okay, you suspect this. When do you suspect respiratory alkalosis? Whenever a patient is tachypnic, for any reason, pneumonia, anemia, any of those. Also, my early hepatic coma, early sepsis, you can get respiratory alkalosis. In severe, you get metabolic acidosis. So, now having known the history, then you look at the blood gas and try to understand what it is. I won't go into the detail, but trust me that for the same blood gas report, if I tell you he's a healthy 37-year-old man having had cholecystectomy, the interpretation of this is acute respiratory acidosis. If I change the history and say he's a chronic COPD, he's confused, he's been alone, he's been unwell for a few days, the correct interpretation is chronic respiratory acidosis and metabolic acidosis. Same blood gas, no metabolic acidosis to metabolic acidosis, both are correct depending on the history. So always patient first, blood gas report second. Have you understood this? Having got the blood gas report, you must analyze how is the oxygenation status, how is the ventilation status, and how is the acid base status. Oxygenation status, you look at few things. One is whatever, whether he's on 100% oxygen or 50% or room air, on ventilator, off ventilator. First thing as a clinician is he able to maintain PO2 between 60 to 100? If he's able to do that, you know that you don't have an emergency on hand. So oxemic status means absolute value in blood. If it's 60 to 100, you know that he's safe range. Then we think what we expected and what we are observing. Now having got say 70 PO2, it matters to me whether it's on room air or 100% oxygen, because it cannot be the same. So then I start looking at whether what is expected, what is not expected. How do you know how much is expected? 5 times the FiO2 is what I will expect. So on 40% oxygen, I expect 200. On 100% oxygen, 500, 5 times. So this person with a PO2 of 70, which is safe range, if he's on room air, I am happy. If he's on 100% oxygen, he's got severe ARDS. Have you understood the significance? And then you look at the oxygen cost of breathing, which is more important on outpatient basis. Two of us have PO2 of 70. He is breathing at 20 breaths per minute, I am breathing at 40 breaths per minute. PO2 is 70. Are our lungs equal? No. His lungs are better because he doesn't have to exert. I have to exert a lot and therefore my lungs are not so good. And therefore, you look that is what is oxygen cost of breathing. How much efforts am I making to maintain that PO2? This is about oxygenation status. Shall we do one or two test questions just to check oxygenation status? Have you understood? Now, there's one more thing you should understand in oxygenation when you're talking about is, whenever I want to know why PO2 is low, I must calculate the alveolar arterial gradient. Must. Alveolar arterial gradient is a gradient between the PO2 in the alveolus and in the capillary. That gradient normally is not more than 15. You do that by 713 into the FiO2 which you are giving minus PCO2 into 1.25. This gives you alveolar and the red one is the arterial. Subtract them, you get 15. Alright. If it is less than 15 or 15, patient has no lung problem. Though PO2s are low, the cause is extrapulmonary. If the gradient is high, then only you can suspect a lung disease. That is the important. Now let's do this question. A 32-year-old female with 32 weeks of pregnancy meets with a motor vehicle accident. She has rib fractures, is on painkillers, but is comfortable. BP is normal, abdomen non-tender. This is the ABG report. What is the most appropriate answer here? It's an audience response. Would you say very good oxygenation, she can be transferred to the ward and continue painkillers? Or would you say she has undiagnosed lung contusion? Or would you say the oxygen electrode needs calibration? Or would you say that supplemental oxygen can be stopped because PO2, we don't need 150 PO2? Starts now. Audience response, so everyone can answer on their own. Okay, there are 32 people to begin with. Let's see how many people answer. What would you do in this situation? Suppose this was a patient with you. And remember, I don't know who is answering what. Okay, what it shows is that many of you didn't answer. Most of you thought B and then some of you thought A. B is that she has undiagnosed lung contusion, and you're very right. She has undiagnosed lung contusion. Though PO2 is good, how much should it have been on 50% oxygen? 250. Why it is not 250, it is 150 means with this history I would say either a pneumothorax or a lung contusion. Alright? But the correct way to do it is calculate alveolar arterial gradient 713 into 0.5 minus PCO2 is 42 into 1.25. You get 303 minus 150 is 153. Normal is 15. 153 is a high gradient. There is a significant lung pathology, either pneumothorax or lung contusion. Many people make this mistake of saying, yeah, she's comfortable, PO2 is sent to the ward. Okay. Another female on ventilator post laparotomy. So she had a laparotomy done. She comes to the ICU. After 1 hour, you do a blood gas and you find this blood gas. What do you think is the most appropriate answer? Very good oxygenation, she can be extubated, FiO2 can be reduced to 30%, or I cannot rely on this ABG. Audience response starts now. You're all sitting here because I presume you want to learn blood gases. Must answer. If you don't answer, then you will not learn ABGs. That's all I can tell you. Okay. Third prize, second prize, first prize. It looks like this. 12 of you said C. ABG cannot be relied upon. I think you've understood the trick of how I frame my questions. Whatever is obvious, don't answer that. What you think is wrong, answer that. Okay, good. It cannot be relied upon in this situation. Why can it not be relied upon? If you calculate the alveolar arterial gradient, you get an answer of minus 14. Minus 14 means Oxygen is going from the body into the alveolus into the air. Only trees do that. Do we give off oxygen? No, only trees give off oxygen. So this is a situation which cannot occur. Even if you don't do this calculation, you say at 0.45, how much would I have expected PO2? Less than 240. So why suddenly there is more oxygen than it's theoretically possible? The blood gas is wrong. Okay? So you've understood oxygenation status. What about ventilative status? Ventilative status means you only look at the carbon dioxide. Normal PCO2 is 35 to 45. If this is less than 35, he is hyperventilating and removing the carbon dioxide. And if the PCO2 is more than 45, he is not washing out, he is retaining the carbon dioxide, so he is hypoventilating. Now, the same patient that we had, pregnant female, PCO2 is 40. Question is she hypoventilating, normal ventilation or hyperventilating? Audience response. So we have to compare with normal. Is it normal for her? Is it abnormal? Is it more or less? And that will decide the. Okay, majority of you said she's hypoventilating. You're good. She's true. Though the PCO2 is between 35 to 45, pregnancy is the only condition in which you cannot call it pathological. Can you call pregnancy pathological? No. Where because of her hormones being very high, her diaphragm being high, the tummy being more voluminous, there is a state of chronic hyperventilation. And their normal for a pregnant female is a PCO2 of 30. And for 30, 40 is high, she is hypoventilating. Why is she hypoventilating? The pneumothorax, which was in this patient with lung control. Okay. You are called to the casualty to appoint on the ABG of a 65-year-old male with mild abdominal pain. The medical officer is concerned that he has got a barrel chest and saturation is low, so he asks for a blood gas. This is the blood gas. I want you to now tell me which of this response is appropriate based on your understanding of ventilative status and oxygenation status. Look at it for some time, then I will start the timer. Timer starts now. Okay. Votes divided between C and D. Admit in ICU, give oxygen, antacid and antibiotic. Admit in the ICU, intubate and ventilate. Either you are very good with blood gases or you just know now what to answer. It's admit to the ICU, intubate and ventilate. Why am I saying that? Patient has come on outpatient basis, casualty, why are you admitting, intubating, ventilating? Is because if you calculate the alveolar arterial gradient, it is 15. Now this patient looks like he's got COPD. He's got a barrel chest, PO2 is low, PCO2 is high. You think he's got COPD, but gradient is normal means there is no lung pathology. How can you have COPD and the lungs are normal? So this rules this out, and the cause of low PO2 here is hypoventilation. This patient was an interesting patient who stayed close to the hospital. Old man, he wanted to die. He wanted to commit suicide. He had some sleeping tablets, okay, barbiturates, etc. He needed analgesics, painkillers. So he took all of them. He thought he'll die peacefully, but when he started getting acidity and pain in abdomen, he came to the casualty. I want to die, but not with pain in abdomen. So it was immediately picked up that his lungs are normal. He's not a COPD. He was intubated, ventilated. Serum barbiturate levels very high, and therefore he was treated, and then he was given counseling and sent home. If he had not done that, he would have died. He would have had a cardiac arrest. And the last component is acid-base status. Oxygenation status, we finished ventilation, acid-base. This people find most difficult. So we'll go step by step starting from basics. there are only two types of disorders, acid-base: metabolic disorders and respiratory disorders. Metabolic disorder is one in which the problem is with the bicarbonate, and respiratory is one in which the disorder is with PCO2. When PCO2 dissolves in water, it gives you H2CO3 acid. So CO2 is actually an acid. If the PCO2 is high, we call it respiratory acidosis. CO2 is low, we call it respiratory alkalosis. Now bicarbonate is an alkali. If you have too much of bicarbonate, it's metabolic alkalosis. Too little, you get metabolic acidosis. Is this understood? So there are four problems you can have: metabolic acidosis, metabolic alkalosis, respiratory acidosis, respiratory alkalosis. Only four primary disorders. Whenever there is a primary disorder, the body tries to compensate. So if it's acidosis, the compensation will be alkalosis. If it's metabolic, compensation will be respiratory, and vice versa. But by consensus, whenever we speak of a disorder, we speak only if we are saying it's primary. If we are saying it is compensatory, we don't talk about it. So a patient with metabolic, I say this man has metabolic acidosis. Now the fact is, of course he's got metabolic acidosis, but he will also have a respiratory alkalosis as compensation. I will not talk about it. A patient with diabetic ketoacidosis, I'll say he's got metabolic acidosis. Respiratory alkalosis is compensatory, I don't talk about it. Now if this patient, I say, has metabolic acidosis with respiratory alkalosis, I am saying metabolic acidosis is primary due to decay. He's vomited, aspirated, now he's got also primary respiratory alkalosis, then I will say. But if it's compensatory, I will not talk about it. Is this point clear? Now, so how you approach an acid-base disorder is always first identify the primary disorders. You pick up any primary disorder and then look at the compensation, is it appropriate or not. It is very mathematical. Compensations are predictable and there is no such thing as overcompensation. I don't know last time when income tax refund gave you excess money, did they overcompensate you any time? I know hundreds of times they have compensated less. Never overcompensation. If it's overcompensation, then there is a second pathology causing that overcompensation. Okay? Second pathology. So if it's beyond or less, there is a second disorder. And always give a complete diagnosis. If I say Rajesh is unwell, you may say Rajesh Sharma, Rajesh Gupta, Rajesh Walia, you will not know. So complete means first name and last name. Same way in metabolic and acid respiratory disorders, I will show you what a complete diagnosis is, and then finally talk on the etiology. What is the cause? What is the clinical implication of that? How do you pick up primary disorders? Very simple. Look at the pH. pH is less than 7.35, acidemia. So there has to be an acidotic process, either metabolic or respiratory. If the bicarb is low, then it is metabolic. If the PCO2 is high, it's respiratory. Simple. Same way, if the pH is high, alkalemia, look at the bicarbonate in PCO2. If the bicarb is abnormal, it's metabolic alkalosis. PCO2 is abnormal, it's respiratory alkalosis. So primary disorder should be very easy to pick up. Once you picked up the primary disorder, you look at the complete diagnosis for which you will have to work up. What do I mean by, never say metabolic acidosis. Always say high anion gap or normal anion gap. Never say metabolic alkalosis. Always say fluid responsive metabolic alkalosis, fluid unresponsive metabolic alkalosis. Respiratory acidosis or alkalosis, always say acute or chronic. Very important. Now just to take an example. This patient with diabetes comes to you. I want to pick up the primary disorder. Look at the pH is low, acidemia. PCO2 is low. This will cause alkalosis. It will not cause acidity. It doesn't explain this, so this is wrong. Bicarb is low. Normally should be 24. This explains it. So there is a metabolic acidosis. This is the primary disorder. This is how you pick up primary disorders. Shall I go ahead? Now, once you picked up a metabolic acidosis, it's not enough unless you can find how does it affect my patient's management or diagnosis. And the various causes of which you should pick up what is the cause. And the way to do this is, whenever you have metabolic acidosis, bicarbonate is low, look at whether the CO2 is appropriately in its compensation. And the way to do this is, don't get confused by that slide. Look at me for a minute. This is compensation people find difficult to remember. Very simple. Start with thinking that metabolic acidosis, what happens? Bicarbonate falls. So whatever the bicarbonate falls by from 24, PCO2 will fall by the same amount in metabolic acidosis. So bicarbonate from 24 becomes 20. It has fallen by, PCO2 will also fall by 4, from 40 it will become 36. So if it is 30, there is a respiratory alkalosis. If it is 36, 37, something like that, it is only it's appropriate, so it's only a metabolic acidosis. Have you understood this? If it is 42, it should have been 36, it's high, so there is also a respiratory acidosis. Very simple. So in metabolic acidosis, it is by same amount. In metabolic alkalosis, bicarbonate increases, but PCO2 increases by half the amount. So if my bicarbonate from 24 has become 30, it has increased by 6. PCO2 will increase by half that amount. From 40 it will become 43. Have you understood how to predict compensation? More or less means there is a second disorder. Is that simple to remember? So don't go into various formulas. At the bedside, this is what you should remember. Second is, so that you look at compensation, you picked up other primary disorder by that method. Then look at compensation. And here, so you look at anion gap. Now you must understand anion gap is very important in the approach to acid-base disorder. We will come back to, so we will understand first what is anion gap, but you must calculate the anion gap and also calculate in this person how much it should be. So this is the actual value, this is the reference value. If I were to compare Japanese girl 4 feet tall, and I cannot say tall or short comparing it to an American. I have to compare it to a Japanese. Same way Indian I have to compare to an Indian. An American I have to compare to an American. Isn't it? A 4 feet Japanese may be normal. So 4 feet is the actual value. Expected is, what would I have expected in that situation? If it's 4 feet, it is normal. If it expected is 3 feet and it is 4 feet, it is high. If it should expected is 6 feet and it is 4 feet, it is short. Have you understood this? So high anion gap, normal anion gap is dependent on comparison of actual anion gap and calculated anion gap. So let us see what is anion gap. Now in the body you have certain positive ions and negative ions. So you have got sodium, potassium as positive ions which we call cations, and you have got chloride, bicarbonate which we call anions. In the body what we measure is usually sodium and potassium, and here chloride and bicarbonate. Do we measure sulfate, phosphate? Do we measure copper, zinc? We don't. So this is just so, and the difference between potassium and sodium is so much. Sodium is like 140, this is like 3.5. People say just say sodium and others. Just say chloride, bicarbonate and unmeasured. Right? Now, but in the body they are equal. If they are not equal, we will become a battery. Current will be flowing in us. If you touch someone, I know sometimes you touch someone, you get a shock. That's not because of anions. Okay? But in the body, if you measure just sodium, chloride and bicarbonate, can you see what happens? Here, sodium is more than the sum of chloride and bicarbonate. I don't measure something here, I don't measure something here. And so sodium minus sum of chloride and bicarbonate, there is a gap. I call this anion gap. Whenever there is an anion, okay, so a normal anion gap is 12. Now, don't forget that anion gap is a man-made thing. There is no such gap in the body. Some scientists made that up. Whenever the bicarbonate falls, we call it metabolic acidosis. So in this is normal for comparison. In this patient, bicarbonate has fallen. So this patient has metabolic acidosis. But if I look at what I measure, I find sodium minus sum of chloride and bicarbonate, the anion gap has increased. So I call this high anion gap metabolic acidosis. Bicarbonate has fallen, metabolic acidosis is high anion gap. Like lactic acidosis, diabetic ketoacidosis, alcohol, all those things. Now there may be a situation where, see, here also bicarbonate has fallen. From here bicarbonate has fallen. But if I look at the anion gap, it is normal. I don't know what this error is it showing. So this is also metabolic acidosis, but now it's normal. This is called normal anion gap metabolic acidosis. Why is the anion gap normal in this case? Because the chlorides have increased to compensate. And also normal anion gap is called hyperchloremic metabolic acidosis. Whenever your chlorides are high, it indicates normal anion gap metabolic acidosis. So once you've classified your metabolic acidosis as high anion gap or normal anion gap, it's very easy. There are only few reasons, 4 reasons for high anion gap: lactic acidosis, diabetic ketoacidosis, renal failure, and alcohol intoxication or drug intoxication, alcohol or salicylate. Very simple. Lactic acidosis, I know if the BP is low, patient is having convulsion,